Hello, Namaste. Today I shall be discussing on acute epiglottitis or acute supraglottitis. Acute epiglottitis is defined as rapidly developing inflammation of the epiglottis and adjacent supraglottic tissues, usually due to a bacterial infection that can cause life-threatening airway obstruction. This condition is more common in males in comparison to female children, and the mean age is 3 to 4 years of age. But the disease might affect the larynx in children from 1 to 6 years of age. Children till 2 years of age have some form of innate immunity. Children after 6 years, they have immunity against H. influenzae. Therefore, the disease mostly happens in children from 3 to 4 years of age. Whereas, H. influenza meningitis is common in children below 2 years of age. The postulated theory for epiglottitis happening in 3 to 4 years of age children is that previous exposure to H. influenzae leads to type 3 Arthur's reaction, and that leads to acute epiglottitis or rapidly developing airway obstruction. It is more common in winter months. As you know, all the viral infections are common in winter months. Most common causative organism for acute supraglottitis is Haemophilus influenzae type B, HIB. Next are Staphylococcus pyogenes, Staphylococcus pneumoniae, and Staph aureus. Occasionally, tubercular bacilli also might affect the epiglottis, leading to acute epiglottitis, but it's more common in adults. Acute epiglottitis might lead to life-threatening airway obstruction, requiring intubation or tracheostomy, but is rare nowadays. The mortality used to be around 30% in the past, but nowadays the mortality is still around 1% in children if they are affected by acute epiglottitis. The disease leads to sudden onset and rapid progression with early airway compromise in children that happens within hours, but in adults the course is more indolent and that takes days for the disease to cause problems. So in adults it is not an emergency, but in children this condition is emergency because of soft tissues in the supraglottic area which can rapidly swell. Let's come to the clinical features of acute supraglottitis. As you know, the disease onset is acute, so-called acute supraglottitis, and progression is very rapid. The child might develop airway obstruction within hours. The child presents with severe sore throat, oronophagia, and dysphagia and drooling. The child cannot swallow his or her own saliva. The child, when presents to emergency, will be in respiratory distress with inspiratory stridor. When the child has more of the respiratory problem, the child might be floppy, and we think that floppiness is due to respiratory failure or respiratory fatigue. The child will be quiet, will be pale and terrified. On examination, the child will have a toxic look, and the child might have fever and lymphadenopathy in the neck. The voice will be muffled because of supraglottic edema. The child may lean forward, extending the neck to maintain an open airway, because if the child leans forwards, then the edema will be slightly less. As you know here, the edema will be more towards the entry aspect. Therefore, if the child leans, there will be some form of airway in the child. Tripod sign is classic in acute epiglottitis. It refers to as sitting up on hands with the tongue out and hair forward like a dog. The neck nodes will be enlarged. If we suspect acute epiglottitis, the examination should be carried out in ICU or emergency room with intubation or tracheostomy if ready, because if the child gets frightened, there will be more of the airway obstruction. During examination, we can see inflamed epiglottis, aryepiglottic folds, and arytenoid cartilages, that is supraglottic area. Therefore, it is called as acute supraglottitis. Occasionally, pus might be seen in the epiglottis, which signifies abscess formation in the epiglottis. You can see here, this is the swollen epiglottis. All of the supraglottis area is swollen, and this is also swollen epiglottis, and you can see the saliva here. So this condition is called as cherry red epiglottis. You can see the epiglottis is like cherry red. Most of the times the investigations are not required, but plain X-ray soft tissue neck lateral view can be performed when the child is stable. In that condition, you can see enlarged and swollen epiglottis, which is also called as thumb sign, and there will be absence of deep, well-defined vallicula, also called as vallicular sign. So thumb sign and vallicular sign are the signs of acute epiglottitis. We can take culture from the epiglottis during intubation, and yes, influenza might grow on culture from the epiglottis. Blood culture and throat swabs are also not usually performed. Yes, most of the times it's a clinical diagnosis. So this is the swollen epiglottis, this is hyoid bone, and this is the epiglottis swollen part, especially supraglottic area, epiglottis. Then it's a thickened AE fold which can be seen on X-ray. This signifies acute supraglottitis. This X-ray shows epiglottitis in elderly individual, which is less severe than children. As I have already told, in children, the supraglottis area is more lax than in adults, where the supraglottis area is slightly strong. How to treat acute supraglottitis? Once the diagnosis is made, our priority shall be to ensure patient's airway by either intubation or tracheostomy under general anesthesia if respiratory distress or stridor occurs. If the child is not having any respiratory distress or stridor, then the child has to be looked upon in ICU with continuous monitoring. When intubation is required, the child is mechanically ventilated until swelling and inflammation decreases. Usually the swelling and inflammation decreases by 24 hours, so the child can be extubated by 24 to 48 hours. Careful monitoring and isolation is required because the condition is infectious and the infection can easily spread to others. Therefore, it is important that the child be isolated if possible. Steroids are the mainstay of treatment as they are strong anti-inflammatory agents. Prednisone in the dose of 1 mg per kg stat followed by 1 mg per kg every 6 to 8 hours is given. Dexamethasone 0.6 mg per kg stat can be given. Steroids can be continued for up to 2 to 3 days to see the response. Antibiotics, which are active against Haemophilus influenzae, are to be given. Ampicillin in a dose of 200 mg per kg per day in 4 divided doses, that is 50 mg per kg per dose, and chloramphenicol 100 mg per kg per day in 4 divided dose, again 25 mg per kg per dose can be given, which is active against Haemophilus influenzae. Ceftriaxone in a dose of 100 mg per kg per day in 2 divided doses, or cefuroxime 50 to 100 mg per kg IV twice a day can be given. Nowadays, we prefer giving cefuroxime for the patients with acute supraglottitis. This is second generation cephalosporin. The child has to be adequately hydrated. There might be respiratory distress, there might be sweating, the child might be in shock. Therefore, adequate hydration should be there for the child. We can give IV fluids. Proper oxygenation is required because the child will be hypoxic in the early stages. Therefore, oxygen can be given as required. If the child is intubated, then sedation is required. We can give either midazolam 0.1 mg per kg bolus and continuous IV infusion if the child is intubated only. So if the child is not intubated, we need not give sedation. But if the child is more irritable, then we have to sometimes give sedation. This is all regarding acute supraglottitis. You might get either a short note or few MCQs in examination. Have a recapitulation on acute epiglottitis if you have not studied properly. Thank you. Thank you very much.